Hi, Dr. C here. A few months ago, I built a PainFinder quiz, and I've been reviewing the data, and I'm finding some interesting results. I'm going to give you some information about what I'm learning today. When most people think about back pain and sciatica, what they're talking about is pain that radiates from the low back into the buttocks, down the leg, into the bottom of the foot or the outside of the foot. It gets worse when you bend over. It improves when you lie down and elevate your legs. It is the definition of sciatica. It is actually fairly prevalent in my data set, but what I've also found is that there's another particular nerve root problem called upper lumbar radiculopathy that is also highly represented in the data that I'm reviewing, but is something that almost nobody ever thinks about when they're looking at back pain. Sciatica is called sciatica because it is an irritation of part of the sciatic nerve. The sciatic nerve is made up of nerve roots from L4, L5, and S1 predominantly right at the base of the spine. And the reason that you feel the pain traveling down your leg and into your foot is because those nerve roots contribute to the sciatic nerve, and that's where the sciatic nerve travels, down the leg, into the bottom of the foot. But there are other nerve roots in the lumbar spine that are not part of the sciatic nerve, and they can also get irritated from a disc bulge or narrowing of the canal or instability in the spine. And these result in a completely different pain pattern from sciatica. And because of where these nerves travel, they're often misdiagnosed. And I'm finding that the prevalence in the general population is actually very high. Whereas when I review the textbooks and I look at research papers, the incidence is reported at somewhere around 2 to 3% of all lumbar spine pain. I'm seeing that it's much closer to 12% of all back pain. The upper lumbar nerves, L1, L2, and L3, don't run down the back of the leg. They actually run into the hip, they radiate around into the inner thigh, and then they travel down into the inner part of the knee and the shin. And so when people have pain in these areas, the brain tries to make sense of it by attributing it to structures in the area, most likely the knee or the hip. And so you assume that you have hip pain because it hurts in the hip area, in the butt, in the outer part of the hip and into the groin, and then into the inner thigh. Or you assume you have knee pain because the pain radiates into the inner part of the knee. So they go to their doctor, they get sent to physical therapy, people work on the hip and the knee for an extended period of time. It fails to improve, then they get an x-ray, which really doesn't show any abnormality. You continue with the physical therapy, treating a joint problem. Ultimately, you get an MRI and it comes back normal. The interesting thing about these upper nerves is they carry a high percentage of stabilizing and motor fibers for the hip and knee. And so the symptoms are pushed in the direction of these joints, and the brain makes sense of it as joint pain. You can even see inconsistent pain with examination of the joint, but it usually doesn't follow a typical physiological pattern of injury. These nerves innervate the psoas and the iliopsoas. They innervate the medial quadriceps. They innervate the hip flexors, and they also innervate the capsule of the hip joint. And that's why you feel the symptoms inside these joints. The other thing that happens is the brain isn't just receiving a pain signal, it receives an error in motor signaling as well. And so the brain interprets it as joint instability, even if the joint is fine. So what is the response? Well, the brain signals the muscles to create spasm, to try and stabilize the joint. That's a very old physiologic response to injury. When you get hurt, the first thing you see is swelling and muscle rigidity in an effort to protect the joint, to stabilize you so you don't further injure yourself. So now you've got spasm, you start to limit your range of motion in the joint, and it sort of becomes self-perpetuating. And the brain has no idea where the pain is coming from. It's assigned it to the most logical area, and it's also assigned it to the most vulnerable area, and then it's created a whole system of response for protection. So you come in limping, it's clearly in your hip as far as you can tell from where you feel your pain. And without a careful exam, and more importantly, careful history, you'll miss the information entirely that we're picking up on this quiz. If you want to do the evaluation for yourself, all you need to do is just sit up tall in a chair, raise your knee up towards your chest and push down. Take your hand and push down on your knee. If the muscles feel weak or they reproduce your pain, you may have a radicular pain rather than a joint problem. Joints usually show up as painful with range of motion of the joint, not with just flexion of a muscle or flexion against resistance. So now what is happening is the nerves are firing continuously. They remain hyperexcitable. And even when the nerve pressure is released, say you have a disc bulge that's irritated the nerve becomes irritated, it swells. The disc is not physically injuring the nerve, but you still feel the pain. You develop a hyperexcitable state, and this turns into a neuropathic chronic pain. With proper diagnosis, you can move on to proper care. And with proper care, you can relieve the irritation of the nerve root, let the signals wind themselves back down, calm back down, and you'll find that after the spinal nerve irritation is resolved, the joint pain resolves with it. If this is interesting to you, you should check out the PainFinder quiz and take a look for yourself. See what your back pain signals might mean. I'm Dr. C. Thanks for watching.